Thank you all for attending the webinar to learn more about health information exchange and how it relates to meaningful use. My name is Chris Becker. I'm a project specialist with Metastar. Metastar is the quality improvement organization for the state of Wisconsin. We're also fortunate to have with us today Joe Kahelski. Joe's the Chief Executive Officer for WISHIN, also known as the Wisconsin Statewide Health Information Network. In his role, he has overall executive authority for the operations of WISHIN. When he joined WISHIN in 2010, Joe had 24 years of experience in the healthcare and health insurance industries. He previously held key positions at the Wisconsin Physician Service Insurance Corporation, Physicians Plus Insurance Corporation, and the Wisconsin Association of Health Plans. Most recently, Joe was the first executive for the Wisconsin Hospital Association Information Center, a subsidiary of the Wisconsin Hospital Association, where he oversaw the privatization of hospital data collection and reporting functions. And welcome, Joe.
Good afternoon.
Thanks for joining us. First of all, let's review the objectives. I'll be reviewing at a high level what a health information exchange is, the meaningful use objective 5, and options available to meet the measure. Joe will then be discussing how Wisconsin's statewide HIE or Health Information Exchange can help providers to meet the meaningful use objective relating to HIE. What is Health Information Exchange? At a high level, HIE or Health Information Exchange allows providers and other personnel to share up-to-date patient information securely and electronically and access that information in a timely manner. Why use Health Information Exchange? Well, HIE improves the speed of retrieving a patient's data as it is immediately accessible in most cases. With that information at the ready, providers can then make better informed decisions that take into consideration patient information that he or she may have not been able to access in a timely manner otherwise. This leads to better patient care and increased patient safety. It also allows providers to deliver more personalized, high-touch care because they're making much more informed decisions and have a better overall view of the entire patient history and picture of the situation. Utilizing the information within an HIE reduces costs also to the patient and the provider, which will be highlighted in the next slide. How will HIE improve care? With providers having the ability to view additional patient data beyond what is available in only their EHR, they can provide higher levels of care management to avoid costly readmissions and duplication of expensive medical tests. With medications being listed from multiple sources, such as hospitals and other providers, medication interactions can be avoided, allergies can be addressed, and it will also allow identification of potential drug-seeking behavior, which has become a high priority lately given the opioid epidemic. With regard to the future of HIEs, what we're going to continue to see is HIEs are going to continue to expand, they'll be interconnected, and ultimately information will be shared across state lines and directly in the EHR. Some of that is occurring now, and Joe will touch on that, but there's still some barriers and hurdles to overcome there to be fully connected. And obviously this will allow patients' information to follow them into different states, for instance, snowbirds from Wisconsin and Arizona or Florida being a good example of that.
Oh, actually,
Just a reminder to keep the phones muted, please.
Actually.
Now let's take a look at the meaningful use objective, objective number 5, which is related to health information exchange.
This is all he's doing.
Can we make sure our phones are muted, please?
I don't want nobody feeling like that.
Meaningful use objective 5 is the objective that directly relates to HIEs. Kind of 3 parts to the meaningful use objective. it's a statement of the overall objective, measures that need to be met within the objective, and then some exclusion criteria if applicable. We'll take a look at each component and discuss it in detail. The objective, you know, as it states there, the eligible professional or EP who transitions their patient to another setting of care or provider of care or refers their patient to another provider of care provides a summary of care record for each transition of care or referral. And just a little definition here. Transition of care is the movement of a patient from one setting of care, you know, examples being a hospital, an ambulatory primary care practice, a specialty care practice, long-term care, home health, rehab facility to another facility. At a minimum, this includes all transitions of care and referrals that are ordered by the eligible provider or EP. There are two measures within this meaningful use objective. The first one is that the certified EHR technology is used to create the summary of care record, and the second measure being that the summary of care record is electronically transmitted to the receiving provider for more than 10% of care and referrals. Then, as mentioned, there's also an exclusion for this measure. If the eligible provider transfers a patient to another setting or refers a patient to another provider less than 100 times during that EHR reporting period, they would be able to meet this objective by exclusion. You know, in other words, get credit for it without doing it if they meet that criteria. There are three different ways detailed in the objective that allow us to meet this measure. The first is the use of the secure transport capability built into the EHR that was needed to be there to be certified. That's known as the direct protocol. There's another method called the SOAP, Simple Object Access Protocol, that can also be allowed to do this transfer. We won't drill down into that, but that's another option that some vendors may have pursued. And then the third option is use of your certified EHR technology to create a summary of care within the EHR, and then engaging an external HISP or Health Information Service Provider to be able to do the transport of that continuity of care document. At a real high level, here's how that direct messaging would work. It works essentially, it's a secure email essentially. Provider sends a direct message, message transmitted through the Health Information Service Provider or, you know, somebody like WISHIN, transmitted to the recipient's EHR to their HISP vendor or WISHIN to their EHR, and then the provider receives the message and opens it. The other meaningful use objective, Objective 10, public health reporting, is another meaningful use objective that WISHIN could be leveraged for. Currently, they are able to help submit immunization data to the Wisconsin Immunization Registry. Still need to register with FREDS, the public health entity in Wisconsin, to work directly with WIR to declare your intent to do that. Syndromic surveillance, I believe Joe will touch on this, but also they would have the ability to do that, but in Wisconsin at current, DHS has stopped accepting syndromic surveillance information from ambulatory providers, so that's kind of on hold at this point in time. But the immunization information is definitely something that they can assist with. And with that, I'll turn it over to you, Joe.
Okay, thanks, Chris. Welcome, everybody. Can you hear me okay?
Yeah.
Okay.
Yes.
Okay, Laura Witter of my staff is also on the line, and to the extent we get into some technical detail, she's going to be here to help me out with that. So go ahead and Go to the next slide, Chris. Chris mentioned that we have two main products, WISHIN Pulse and WISHIN Direct Plus. I'm going to talk about both of them. Most of our clients use our WISHIN Pulse tool, although we do have some clients using WISHIN Direct Plus as well. Each of them are ways in which you can satisfy the transition of care requirements under meaningful use. Pulse is a query-based exchange, meaning bidirectional. It's a community health record, and we'll talk about what that means. WISHIN is an e-health exchange participant, and as a matter of fact, we were one of the first statewide health information exchanges to be onboarded to the e-health exchange. You can think of it as kind of the interstate highway of health information exchange. It's a way that HIEs like WISHIN can communicate with other HIEs, and participants with WISHIN can connect in a limited way to participants of the e-health exchange in other states. WISHIN Direct Plus is direct secure messaging. Chris talked about that being one of the ways you could share electronic care summaries and meet the meaningful use standard. So we are a Direct Trust certified HISP, Health Information Service Provider, and we're essentially a secure email carrier, if you will, and we have directories. Everybody who's a user has a WISHIN Direct Plus address, and we maintain those directories. We also maintain directories of other organizations that aren't part of our HISP, but there may be a need to communicate with them. We are, as I said, Direct Trust certified. Essentially, that means that you can use our HISP to send messages to other HISPs. If you think about a cell phone situation, you can use your U.S. cellular phone to call a Verizon phone. Similar with HISPs, they're interoperable with each other. Go ahead.
Siri, remember to mute your phones, please.
So WISHIN Direct Plus, I've touched on this. We have about 6,500 direct addresses right now. WISHIN Direct, we sell direct services as a standalone service, and it is also kind of embedded in our Pulse product. So if you are a WISHIN Pulse subscriber, you get WISHIN Direct functionality at no additional charge. So let's go ahead to the next slide. So I'm going to spend most of my time talking about WISHIN Pulse. That's really the core of what we do. Pulse is a community health record. It's a way to aggregate clinical data about a patient, regardless of where they've, had a healthcare encounter, and present it in a longitudinal way to the person who's treating the patient, so for clinical decision-making and for transition of care purposes. It is a patient-centric record, and what I mean by that is that any, healthcare encounter that's part of our network is going to contribute data to the community health record, but it doesn't get displayed in provider-specific chunks. And what I mean by that is you're not going to see, information from hospital A in one bucket and hospital B in another bucket and clinic C in a different bucket. It's aggregated so you can see it all consolidated under a single patient. The types of data that we make available through Pulse are several. We have ADT, admit, discharge, transfer. Most of that is demographic information about the patient, but there's high-level clinical information like a problem list, allergies, diagnoses. We have radiology results, lab and path results, transcribed reports. One of our clients, Ministry Healthcare, is sharing EKG images and care summaries, electronic care summaries, also referred to sometimes as PCDAs. And these are the These are the electronic care summaries that must be shared in a transition of care situation to meet the meaningful use criteria. There are three other categories of data that are available through WISHIN Pulse that are not contributed by participating healthcare organizations. Two of which are databases that the state maintains. One, the Prescription Drug Monitoring Program. That's the state's controlled substances database, so opiates and other similar drugs, and the Wisconsin Immunization Registry. And so that's the immunization history and schedule information. So what I mean by integration is that when you call up a patient's community health record in WISHIN Pulse, we are querying the PDMP and the Wisconsin Immunization Registry in the background to bring forward the information about that patient in those two databases and display that within the community health record. So there's no need to separately log on to those systems and search for the patient. So the controlled substances and the immunization history and schedule information is presented as a part of the overall community health record. Recently, this year, we've added Medicaid prescription fill information. So basically, just about any drug that Medicaid pays for a patient is going to be displayed in the community health record. Everything else in here is real-time. Medicaid prescription fill is not quite real-time. It's refreshed twice a day. Chris mentioned that, although we are doing syndromic surveillance interfaces for a number of clients, the state of Wisconsin Department of Health Services has kind of put a moratorium on new connections for ambulatory clinics. We're still doing them for hospitals, but that's on hold for the moment for clinics. Go ahead, Chris. Just a couple other things quickly about Pulse. We can deliver results to an EHR. So if you're dealing with, for example, a reference lab, rather than getting information, results faxed to you, we can actually facilitate the delivery of those results directly into your EHR. We can do some notifications. We have a patient activity report, which basically takes a patient population either for a clinic or for a payer, and then we kind of scan our network for activity and basically provide a report every day to the extent that that patient population has had any kind of hospital encounter, an inpatient or an emergency department encounter, admit or discharge. So go ahead, Chris. So Chris touched on the ability that WISHIN has to be kind of a transport mechanism for reporting to the Wisconsin Immunization Registry. So that means that if, for example, you are currently manually entering your immunizations into the Wisconsin Immunization Registry, we can automate that process out of your EHR. So there's some details here about how you go about that. The registration has to be done with the state, and the registration needs to be, the intent to submit needs to be completed within 60 days of your EHR reporting period. The registration puts the client, your clinic, in a queue, and then and just being in the queue will meet the measure. So we'll be working on the implementation, but the key thing from the standpoint of compliance with meaningful use is you're in the queue. Go ahead, next slide. So to take a visual look at how the network kind of works. We've got numerous sources of clinical data, most of which come from the electronic health records of our participating organizations, some of which come from state government sources. And And those are all kind of going into our network. Each of our participating organizations, when they're contributing data, their data is not commingled with any other clinical organization. They're kind of housed separately in a federated model. So each client has their own data stage, is what we call it. Somebody else might call it an edge server. And what sits in the middle is a record locator service and a master patient index. So all you really need to do, and we'll talk about this in a minute, is know the name of the patient, and you can query for their community health record. On the other side of the screen here, we're connected, as I mentioned, to the eHealth Exchange, which is the way we can get care summaries from other states, other providers, and it's the way we can interact with federal agencies like the Social Security Administration and the VA. Let's go next. So this is just a quick walkthrough of how it works. A user of our system would just, enter the patient's name and other identifying information if they have it, like a date of birth or a medical record number. But if you only have a name, that could be good enough. That name kind of bounces off our master patient index, and then the record, we find the right patient, and the record locator service then kind of scans the whole network to find out where this patient may have some records. And that those records are retrieved and brought together on the fly and displayed as a single community health record about that patient. So we're really not storing any sort of aggregated community health record anywhere. It's stored in a disaggregated fashion. And so when it's gone from the screen of the querying user, then it's just really gone. That's the only place it really exists. Next slide. There's some information here about the onboarding process. I won't spend a lot of time on it, but I mean, a general concept here is that, in order to use the system, in order to consume data that is available through WISHIN Pulse, the organization has to contribute data. So we have a standard process to walk through with every organization. So we work with dozens of electronic health record systems. If they're 2014 certified technology, I'm confident that they have the kinds of interfaces that it would be necessary for onboarding. So we have about a 17 to 20 week process by the book. There are some handoff points where the ball's kind of in the client court to help us with validation, et cetera, and to the extent that there's a delay in having that happen, well, that 17 to 20 weeks may stretch out into a longer time period. We start with some sample data from the client, and then we analyze the data, and then we go into various testing and validation processes. And at the end, the information will go live. We'll work with the organizations to train their users, and the administrator at the client side who would handle the user administration for each client. We also will talk about the patient choice process. That is an opt-out. Patients have the right to opt out, but we don't want our clients to have the burden of sort of explaining that process. We'll provide materials that they can give to their patients, and all of the materials sort of refer them to us to the extent that they want to opt out. We manage that centrally. Let's go to the next slide. So this is just some more information about the onboarding process. Again, 17 to 20 weeks. It's kind of a summary of the resource requirements. Is there a question? Okay. Let's go to the next slide. So where are we now in our development? We're coming up on our 6th anniversary in a couple of weeks, and we've grown quite a bit. We have clinical information as to the end of October of nearly 4.4 million unique patients. So that's not everybody in Wisconsin, but it is a good percentage of the population. About 220 million patient events. That's what we call an ADT transaction. And you see the other numbers there, 51 million plus lab and pathology results. Almost 1.6 million care summaries for purposes of meaningful use. That's the sort of gold standard. And you see the other numbers there. And these numbers are growing every month. And so there's a considerable amount of clinical data, including the care summaries, which are the objective under meaningful use. Next slide. So in terms of where those patients, those 4.4 million patients live, this slide is a little bit dated. We're in the middle of updating it, but we have our best penetration in the south and east parts of the state, and not as much in the north and west, but that's changing all the time. And we will be updating this. This is a way to kind of judge the penetration in each county by the zip codes of the patients in our master patient index. So let's go to the next slide. And this is a representation of where our sites of care are. We have more than 1,400 sites of care as part of our network. Again, more represented in the south and east versus the north and west, but this is changing as well. So next slide. Anybody can see our current list of participating sites of care on our website. That's wishin.org. What we hear from our users from time to time. We do some surveys. We get some sort of unsolicited feedback. We hear a lot about the value of seeing that data from other organizations and the relevance of that in terms of clinical decision making. And you know, the workflow is important. We know that we can integrate our tool with your electronic health record system. So, for example, you know, accessing the community health record about a patient, you know, could be just a click from your own electronic health record system. We would have done the patient discovery in a single sign-on way. So, you know, very convenient from a workflow standpoint. Let's go to the next slide. So just to sum up, I mean, from our standpoint, the value of WISHIN, we're enabling clinical information to follow the patient automatically. So we can reduce or eliminate the human error and the manual processes that are often still involved in moving clinical information from one site to another. Still a lot of faxing going on in healthcare, and we would like to sort of eliminate that as much as possible. There's an administrative burden associated with that, obviously. It's kind of an order fulfillment process. You get a phone call, an email, and it's a matter of tracking down that information and delivering it by mail or by fax. And the process of automatically sharing clinical data through WISHIN can ensure that information is available when that patient is seeking care somewhere else, especially when that care transition is unplanned, right? I mean, they show up at an emergency room somewhere, and the emergency room has access to their allergies and recent test results, et cetera. The patient may not even be able to speak for themselves in that case. And so the clinical history of that patient is available immediately to the clinical decision maker. There's a quality of care component here. I mean, obviously more complete clinical information can lead to better clinical decision making and care coordination. And there's a There's a huge emphasis now, obviously, on preventable readmissions. A lot of times, those readmissions result from an inadequate and incomplete or an untimely transfer of clinical information from one patient, from one provider to another. And of course, as we've been talking about today, enabling meaningful use compliance in the transition of care measure and in those public health measures. So let's go to the next slide. I think that is, just pricing very quickly. In the clinic world, basically it's a $3,000 per year subscription. That's for up to 10 providers. And then it's $175 per provider over 10. And so that's the subscription fee. That's a little over $8 a day for the minimum. There's one-time implementation fees to get your data connected, $5,000 per interface, but that's only a one-time situation. Typically, when we're talking about implementing an ambulatory clinic side, it's in two interfaces. It's the ADT and the CCBA. Next. So,
all right.
Time for questions. Happy to answer them.
Yeah, thanks, Joe. That was a lot of good information. Yeah, we've got about, right around 10 minutes here yet. If there's any questions out there.
I should say that to the extent that a client may be interested in implementing with us, we can enable the use of the system, on an inbound basis, more or less immediately while we're onboarding the data in the other direction. If there's an organization that's interested in receiving this information, being part of the network, that can happen rather quickly. The implementation process that we talked about, 17 to 20 weeks, is the process of moving the clinic's data to our network.
Okay, once again, any questions out there? If not, you can certainly contact either Joe or myself after, after the webinar too. All right, well, hearing no questions, Joe, thanks again. I think we'll call it a wrap here, and obviously you can reach out to myself or Joe and with any questions you might have, and we'll get back to you with those answers. With that, I think we'll end the webinar, Joe.
Thank you very much.
All right, thanks for attending, everybody.
Bye-bye.
Thank you.